Thank you, Eleni, for inviting me and also to the society. I wasn't sure what the title meant, so I divided my talk into a major one is to really pose some question from a perspective of a physician who treats adult ALL, using the data of all the age groups that we are discussing. And later on, and the second part is a bit more practical. What should we do and where should we do, where is the future of clinical trials moving? And a lot of things are already being said, so I will actually use some of the data that was shown here. So that is it, the pediatric versus adults and the AYA and clinical trials versus treatment plan. So just a few, a summary. So in ALL, we get 90% complete remission. It's much higher than in AML in the same age groups. Although if we defined a complete remission as a molecular remission, which may be the more correct way, it is probably lower. So we can get a remission, but the problem is maintaining it, and more than half relapse. And when they relapse, the outcome is dismal. It's worse than even AML. There's also, there is no clear data, or it's a controversy about the role of transplant. It's unclear. And we heard about how TKIs improved Philadelphia positive. The problem is that in adults we have no established standard of care. And I know the pediatricians don't have exactly the standard of care, but it's really, and I'll show you what I mean to that. We also don't have a standard of re-stratification, and you can see the NCC guidelines is just pick your favorite then. So how did we get them? These are early trials, many early. So for 40 years, adults are studying. And never was a study that really looked at an individual drug in a complex combination. But if you look at the early trials, it's very interesting that the non-myelosuppressive drugs, vincristine, asparaginase, and prednisone, have a very good, each one of them has a very good activity. In fact, when you combine vincristine and prednisone, drugs that are never used in AML, in adults you can get 50% complete remissions. And in children, I think it's even higher. So that's one point. When you combine these three drugs with a myelosuppressive drug, either Douer in a 5-drug regimen with cyclophosphamide, but still the major part is myelosuppressive, non-myelosuppressive, you increase the outcomes to 85%, what we almost get today. And the third thing is there was only one randomized trial in adults showing the benefit of daunorubicin when it is added to the combination of these three non-myelosuppressive. And that was published in 1984. It's the only trial that shows an activity of a single agent. So where did we move from here? So you see the last papers are in the mid-85, and it's very interesting to read it. So that's where we moved in the last two. The field moved in two separate directions. One is to using variants of BFM models, and I won't define it, but there are certain definitions to that, but adjust it to adults. And the other one is a fundamentally different approach, totally different. And I think you know it, but I'll show some differences that was developed in a single institution. Both have the same complete remission rate, but there are big differences. The BFM model was derived from children with adjustments. Hyper-CVAD was developed in adults. It's never used by pediatricians, although those who developed it extended the age down to 13. The BFM model is much more complicated, and I won't go into the detail, but the main difference is that BFM always has asparaginase, why the Hyper-CVAD never has asparaginase. Although the more modified one try to add it at the end, I think pharmacokinetically, at least cycle A and cycle B, there's no way you can put asparaginase together with it if you understand the pharmacokinetics of the drug. Maybe later on you can do it. However, the Hyper-CVAD has a much more profound and longer myelosuppression, and I think much longer than was originally reported in more recent. And I think the BFM was studied in all groups, that international groups, and the Hyper-CVAD, it's not been really validated in a multi-institutional drug. Of course, I can criticize my own studies that we did it in a single institution, but this is something that stands out. Yet, Hyper-CVAD has become the most popular common treatment in adult ALL, to the point that I am sorry to say that it's almost the de facto standard of care without any justification, because if you look at all the results from the earlier studies, and I put all the groups from Germany, the British and ECOG, and CLGB really did a lot of work, try to modifying the BFM model and the Hyper-CVAD. There's really no overall outcome. And this comparison is especially interesting because these two groups are the only ones that treated patients over age 60 or 65. All the others were limited. So it really, there's a good comparison there. So there's no difference. And the question, why people are selecting it? And perhaps, what I showed earlier, it's just simpler to remember. I don't think it's simpler to use because you've got to give it inpatient and it's a lot of myelosuppression, but at least it's easier to remember. And maybe that is the reason. But so with this in mind, I would like to pose some provocative questions. They're really provocative, and Lenny asked me to be a little provocative here to drive the discussion about how we should look at the treatment of adult ALL. So the first question, and I need to recognize that the outcome of ALL worsens with age, and this is a heterogeneous disease, and also we usually would think as patients who we treat as compared to children, compared to high-risk children. So there will be the high risk. But the question is, should the standard of care shift arbitrarily at the age that is around puberty or 21 years old? I mean, this is an administrative decision. Who goes to a pediatrician and who goes to an adult oncologist? There's no medical data to put that, and I'll go back to it. The second question, is AML-like treatment necessary? And the third one, I think it's been answered several times, is by adapting BFM models from children with optimizing doses of drug, was asparaginase underused? So these are the three questions that I would like to challenge and give some data. So as you know, historically, pediatricians treat patients to an age that ranges from puberty in some countries, like in Spain or in Europe in some places, to age 21 or 22 in this country. And then it shifts to the adults. And in fact, adult oncologists have a broader age range. So now they're starting applying concepts of patients who are maybe 50 to those who are treatment. And the question is, this point here is totally arbitrary. Why this age, the treatment has to change? I mean, why can't we continue? Like we are doing now, we are moving to age 39. And that's the concept of moving the age. In fact, I'm not sure that age 39 is not an arbitrary cutoff. Or maybe we have to move it older, which gets me happier. So I think, and what is the data to support it? So there's few trials, and I think some of them were alluded. First is a subset analysis of older adults treated with contemporary pediatric protocols. Retrospective comparisons of AYA, patients treated by adults or pediatricians. Dr. Advani presented it. And then prospective studies with pediatric regimens in adults. So why are we cracking this age 15 to 21 barrier? So this is the first point I want to make, and using a subset analysis of contemporary pediatric and more intensive approaches in adolescents showed a better outcome than in the same patient, same adolescent, treated historically. And they have moved from levels of about 60% with the more contemporary trials to 70%. So moving that age to age 21 with more aggressive pediatric protocols and getting to outcomes that are similar to younger patients with high risk. So that is one point that I think the cutting at age 21 is really arbitrary. This has been shown already very clear. I think this was the eye-opener of the whole problem, and maybe what developed this conference, I think. So it's clear that I don't think I have to repeat this to this audience. And this is Rivera studies what was mentioned, that you can really cut through the age 21. You can, and this is in Spain, and in Spain they are all treated by adult oncologists. So this is not pediatricians that may know better how to treat children. Perhaps it's true. But here, bypassing this cutoff of 21 by adult oncologists did not change the outcome. So I think this is the first question. The second question, I think has not been answered, and that the role of AML-like myelosuppression. When I learned how to treat AML, the concept was that you have to give them a massive induction chemotherapy to get the marrow suppressed for 3 weeks, otherwise you cannot get a remission, which is true and makes sense because you are suppressing a cell that originates from the bone marrow, so you probably have to suppress also the normal marrow. The question is, this applies also to the ALL. No other cancer uses this, at least I know this is concept. Lymphoma doesn't use this concept. And why should we apply that to ALL? We can use drugs that are myelosuppressive. The myelosuppression is not a goal on its own, but it's a side effect that we will tolerate it, but it's not like in AML. And there are several observations that support that this might be true. So this is the second question. Several studies intensify the anthracyclines without benefits. The very high rate of non-myelosuppressive alone outcome. The BFM inductions more than half are non-myelosuppressive. In fact, if you only use daunorubicin, it's 1 out of 4 drugs is myelosuppressive. There's also AML, which you have 2 very high doses. The low-dose maintenance is another concept, and the pediatric regimens that Dr. Advani mentioned about the non-myelosuppressive drugs issue. So here are just 3 studies, one using CLGB, BFM model, a Hyper-CVAD model, and one is a really AML induction with a lot of mitoxantrone and intensifying the anthracyclines, and all of them with high-dose RSA did not improve any of the outcomes. So I think this question I'm putting this as another provocative question that I think I'm trying to challenge. And the third question is the issue of underdosing of asparaginase, clearly because adult ontologists and Ali referred to, we were afraid even to start a clinical trial because we were reluctant to use this terrible drug. And I'll talk more about it tomorrow when we talk about asparaginase. So why is asparaginase important? And as I say, there's a whole talk tomorrow about it. There is single-agent activity to the drug. So we're looking for new drugs, and this is a 30-year-old targeted treatment which acts as a single agent, actually quite well. There is a dose-response effect, clearly in children, and also some data in adults. In children in high risk, every protocol that changed only asparaginase among multi-other drugs showed a benefit. And in adults, we don't have these trials, of course. And in children now, asparaginase, usually used as a long-acting pegylated asparaginase, is given over 4 to 5 cycles, while in adults it is much less. I'll just show you here some of the big adult studies that were done until 2007. All of them are represented here. Post-remission, no more than 1 or 2 cycles of mostly E. coli, but some pegylated as well. So clearly underused. So can it be used? I think Dr. Advani answered this a little bit, but this is a little bit of data from Germany about pegylated asparaginase, about a dose-response effect in adults, although this may be a little early, between 2000 and 4. This is not randomized. These are consecutive, so these are historical controls, so bear that in mind. And this brings me now to the issue applying all these principles, bypassing the age of 21, no intensification of myelosuppression, and a lot more asparaginase. And this is a summary of what we call the pediatric and pediatric-inspired protocols that are becoming more prevalent after 2007. We have 2 pediatric, one by Dr. DeAngelo, I think you might talk about it. So this is their pediatric model. The CLGB, you heard about it. The results are still pending, but we'll know them soon. Pediatric inspired. So the concepts are there, but there are some little adjustments. Some people are here in the audience. I think from Princess Art, Margaret is here, and the German protocol. But what you see consistently is that the outcome in all of these patients, and the follow-up is quite good, is moving towards the 60 to 65%. There is one problem, is it's not clear if really the patients did get all the prescribed 6 or 7 doses of asparaginase. They may have even got the same doses as the old one. We don't know that, but at least the data suggests that the outcome is better. It's quite compelling. And as you heard earlier, these kinds of models or treatments are fairly well tolerated. I'll talk tomorrow more about our own small study here. And you heard about the toxicity. I think the main toxicity of asparaginase in adults, and I know you were surprised to see it in children, but I think in young children, you don't see the hepatotoxicity. This is the very common, and you can see it here. This is just the induction. You saw this from the 10403. And this is a smaller study from our data, grade 3 toxicity in patients who were treated, we went up to the age of 57, and you can see here that the liver toxicity is very common, 31% of patients or 13% of the doses. But interesting, it's long, but it doesn't cause liver disease. The problem is mostly delaying the next cycle of chemotherapy. And again, I'll talk about it. So this is the problem, but it's not a big clinical problem. The second problem is, and we're seeing it more and more, is the problems with venous thrombosis. I think that almost all our patients are on anticoagulation. So the treatment is fairly well tolerated. So these are the answers to the questions that I asked earlier, and I want to use that for later on for discussion. So how should we treat them now in a practical way? So in my feeling is that we should use a pediatric or pediatric-inspired regimen at least up to age 39. I think the data is compelling enough. But there are certain things we need to consider because we can improve. First, I'm not sure that the upper age limit is 39, but we don't know what is the upper age limit. The French think it's 45. I think Dan, you go up to 50. The Germans go up to 60. We don't know exactly where is the upper age limit. So that needs to be studied. The second thing is fine-tuning the doses of asparaginase, and I think, Adele, you will be talking about the details, and here it's really the details that are important, and that will help the reluctance of adult oncologists of using this drug. Furthermore, adhering to asparaginase toxicity management. I would say early detection of the different toxicities, we'll talk about it tomorrow again, managing them early, treating them, preventing them, you will decrease the toxicity of asparaginase, and this reluctance or fear from the drug will go away. And there's an excellent review that Wendy's talk is the first author, but I think a lot of people here in the audience contributed to writing this paper that can help you. There is a challenge of practical challenge. It is complicated, and there is issues of compliance. And I don't know, we may have to look at it in the same way that transplanters look at treating the patients, but not doing a transplant, having the patients close to the site, because it requires a lot of interaction. So these are the challenges of using a pediatric approach. I won't talk about the older adults. We don't have anything standard. So this leaves me with a question of Hyper-CVAD. Quo vadis? This is not only a movie from 1951, those of you who remember that, but it's in Latin, where are we going? Do we need another fundamentally different treatment that defies the principles that I identified earlier, is not used by pediatricians, does not use one of the most effective drugs, asparaginase, and may have unnecessary myelotoxicity because of the nature of the regimen? And is it really providing better outcome? Now, it is possible, and that's something that we need to know, that in a certain subgroup it might be beneficial. For example, for Berkett ALL, it is a very effective regimen, perhaps more than anything else. But which subgroup in ALL has not identified? So I would like to challenge the discussion and look very carefully. Should this regimen still be the almost de facto standard of care in the community with all the questions? I am not so sure, and I'm looking forward to the next talk about it, but this is where I am trying to provoke everybody here. So in the future, very briefly, this has been discussed. So that was more of a practical, what will we do? And in the future, I think the focus in frontline is now moving, in fact, to immunotherapy. It's not so much the targeted treatment in adults, but it's limited to be lineage. You can't use these factors. Actually, you can't use it in TALL. And we talked about the changing concept based on molecules. And I think the whole area of Philadelphia negative elderly is still totally open. For relapse patients, we have a few novel approaches. I think we have some preliminary data that we can put them as a list according to possible benefit. The TKI is an excellent drug, but what could be a good targeted treatment if we have a very homogeneous population of patients? That may have an excellent. The T-cell therapy, Blinatumumab is a T-cell therapy. The treatment by itself is not active. Is good. It's not clear if these are curing. You'll hear more. And I would say that low molecules are very promising, but I think this was alluded to, but they didn't use the word, is luck. So if you start using the target system and you start looking for mutations, you, by luck, might find something that it will work. And I think that's a very good way to do it. We can use luck a little bit in this disease. So just my final slide. We recognize that there's a genetic heterogeneity, but with a target increasing treatment, we heard about it yesterday, there's going to be diminishing number of patients for clinical trials, which will require prioritization, international collaboration, and including children and adolescents. so we don't repeat the mistake again of separating treatments. And I must tell you, despite what we heard about the targeted treatments in children, it is still very difficult to open new treatments that are used, or phase 1 in adults, to use them in pediatrics. The IRBs and the drug companies are not so ready to combine these two populations. So I hope this will be able to overcome, as again, not to make a mistake where we start separating treatment at a certain arbitrary age. Thank you very much.